Okay, hello everyone. So whoever's here, if you have any questions, just throw them in the chat and we'll handle them as they come. Thank you for the wishes. Does anyone have any questions? I know you guys have had a lot of time to study this because you don't have much else going on right now with just ophthalmology and ENT. So the pressure volume curves, the I'm not gonna ask you any specific questions about them on the exam. The main thing, let me pull up my slides here. It was just to really emphasize that when you have any type of regurgitation, the issue is with volume of blood. So because you have problems with filling, with regurgitation, blood's filling from two areas now, you get a volume overload. So what happens is when you have your normal pressure volume curve, when we have valve issues, valve doesn't close all the way, so we don't get nice crisp lines. And you can see how wide this stroke volume is. Why? Because in regurgitative valve issues, you're filling the chambers from two different areas. With aortic regurg, you have blood going into the ventricle from the left atrium, going in like it normally does, but you also have backup of blood. I drew this really bad, I'm sorry. But the blood comes back in with during diastole. Normally the blood's going to hit the valve, but because the valve is incompetent, it's spread apart, more blood comes in, so you have an increased end diastolic volume with aortic regurg. With mitral regurg, when the heart is squeezing, there's our aorta, left atrium. With mitral regurg, all the blood should go out to the aorta because normally the mitral valve should be closed. In mitral regurg, the valve stays open, so some of the blood goes back up into the left atrium as well. Left atrium now has to dilate and get bigger to accommodate all the extra blood because the left atrium is still going to get its blood from the pulmonary vein. I keep saying R there. Pulmonary vein. So you're getting double the filling. Back up from the left ventricle, back up into the atria, and from the pulmonary system coming back into the heart. You're filling it two spots. So in mitral regurg, you have expanded volume because of the filling from two areas. When you have stenosis, okay, stenosis alters pressures. The amount of pressure that you have to build up to get the blood squirted through a smaller orifice with aortic stenosis, that places a huge afterload on the heart. So your pressures go up. What happens when the pressures go up? The heart's got to squeeze harder, and the heart gets thicker with every single beat. Not with thicker with every beat, but the long-standing aortic stenosis, when you don't treat it, over time, having to squeeze against that increased afterload all the time makes the heart muscle thicker. Heart muscle gets thicker, it doesn't work very well. We went through all that later on. So stenosis causes pressure changes. It's going to alter your afterload. And we know when we alter the afterload, what it does to our stroke volume. So I hope that answers your question regarding the valves. Okay, so lupus with type 2 reactions. So lupus it can do a type 2 or a type 3 reaction. It does both. And again, when it comes to lupus, it depends on wherever those complexes get lodged. That's where you're going to have your problems. So let me pull up my slides here on lupus. Okay, so type 2. Okay, so type 2, remember your mnemonic, ACID, so this is the C. This is cell mediated, which means there has to be some cells that are touching. The main one is going to be an antibody to antigen complex. So we have these antibodies floating around. They're going to trigger a hypersensitivity reaction. They trigger the complement system and cascade, and that causes agglutination, so getting sticky of all these cells. So these are your blood transfusion reactions, as an example. Type 3 is an immune complex. So again, antigen, antibody as well, with regards to type 3. So that's the I immune complex. What else is there on that? Okay. Murmurs. So how do you tell the difference between AR and MS if they're both diastolic? So you have to, one, it's going to be where do you hear the sound the most? So if on the exam or any test question or when you listen to a real patient, if you hear the murmur in the upper right sternal border, that's your aortic valve area. So that's where you're going to hear it the most. Mitral, lower left sternal border, midclavicular line, or even going to axillary line, trying to get that mitral sound when they lay left lateral recumbent or left lateral decubitus. So it depends on where do you hear it most. The other thing about mitral regurg is a holosystolic murmur. So you're going to hear it the entire time and it's going to sound the same. So imagine that left ventricle squeezing really hard, and now you have a very weak mitral valve. And as that blood's leaving to go through the aorta, it's going to, at the same time, go back up and make that mitral valve vibrate real fast. And that vibration is what the murmur actually is that you're hearing. And it's going to happen during the entire time of systole with mitral regurgitation. You asked about the other ones, but anyway, mitral regurgitation, same thing. With aortic regurg and mitral stenosis, aortic regurg, where is mitral stenosis? No, I can't find my slide here. Hang on. Okay, well, aortic regurg. That's all in that video. I didn't play it. Hang on. Right, I gave you all the descriptions. Here we are. So it's a diastolic rumble. So think with aortic regurg, all the blood leaves, but then as the aorta recoils, blood's going to come back and hit that dichrotic notch. So as the blood comes back during diastole, it's just going to fall in like one big bolus down. So the sound is just whoosh, whoosh, in diastole. It's a low diastolic rumble because it's just this blood just falling back into the ventricle. With mitral stenosis, also going to happen during diastole because it's happening during filling. With mitral stenosis, you're trying to squeeze a lot of blood all through one little area. So you're going to have a very similar mild crescendo, decrescendo murmur with mitral stenosis as well. Not as severe as you do with aortic stenosis, but it is a slight crescendo, decrescendo during diastole that you'll hear. So I hope that answered your question regarding the different murmurs. Is it important to know the chart changes in the Wigger's diagram caused by the valve diseases? The prominent V wave changes, yes, because that is something that you're going to have to know regardless because of PD when you do your JVPs. That gets altered depending on what's going on with the heart and how it's working. But as far as, I'm not going to ask you about what change is going to happen because that's not the purpose. The graphs were just to reinforce showing you why you see these changes with volumes, with regurgitation of murmurs, why you see the changes with pressures, and what that does to a heart over time. So I'm trying to get you guys to start thinking about volumes and pressure changes, because when you get to cardio and learning about different types of cardiomyopathy that we learned about, if it's a volume problem, the heart has to accommodate more volume, like with aortic regurg or mitral regurg, the heart has to accommodate more volume of blood. So what happens, the heart's going to dilate and get bigger to cause a dilated cardiomyopathy, essentially, in a way, because it's got to accommodate all the extra blood. So the heart's going to get bigger, get floppy. With stenotic murmurs, they change the pressure. And they're changing the pressure because they are changing the afterload. The pressure the heart has to overcome to get out of the heart. And as that goes up, the heart has to generate more pressure. So the heart is going to be squeezing harder every single beat. Eventually, with these stenotic murmurs, they get hypertrophy. So with aortic stenosis, they get left ventricular hypertrophy because the left ventricle has to squeeze and generate more pressure to get out. With mitral stenosis, they get left atrial hypertrophy because the left atrium now has to squeeze and provide more of a systolic kick for filling to get all that blood through that tight orifice of that mitral valve into the ventricle for filling to get the blood in there. So those are pressure changes. Make the heart thicker. All those things are going to displace the PMI laterally because the heart is getting bigger, whether it's remodeling due to dilated cardiomyopathy or remodel due to a hypertrophic cardiomyopathy. Still a thickened heart, dilated heart, they're not going to work well. You're going to get those signs and symptoms of heart failure. So when you're studying, make sure you also know, the different types of heart failure, what happens, why do they get the symptoms that they get, what are the different causes of right-sided failure, the different causes of left-sided failure, and what the etiologies are. Okay. Okay, next question is the 6Ps with PAD and cardiovascular insufficiency. You will see a little bit with both, it depends. You have to go more of your history with that patient. Smoking history is going to be more arterial issues. Immobility, not moving very much, it can cause vessel issues, more venous problems are going to have more of the venous side of things. It'll be very, very obvious in a question, is this going to be an arterial problem? Because if it's a chronic venous insufficiency, would you still have arterial pulses? Yes, you will still have arterial pulses. With peripheral arterial disease, you will eventually lose those pulses depending on how advanced the atherosclerosis is, where you have these blockages, how bad the blockages are, where they are downstream, and so forth. So that's what matters with that one. Oh, 160, we talked about vasomotor system. Okay, let me look at this real fast. Okay, so vasomotor, we're talking about regulation of our vasculature. And what we're saying here is when, for example, when we stand up and you get up real fast, you do have a transient drop in your blood pressure just from standing up fast. What the vasomotor system does is it kicks in to raise your blood pressure through sympathetic activation to allow you to do your activity real fast so you don't get lightheaded. It happens very, very, very fast. So this way, when you get up real fast, you don't get lightheaded. Some people, when they have autonomic dysfunction, that doesn't work very well. When they get up, they get very lightheaded and dizzy because they don't have the feedbacks from the baroreceptors working properly. So remember, we have the carotid sinuses, we have the aortic arches. They are all sensing pressure. They are baroreceptors. They are sensing the pressure in the system. So when we start sensing we have low pressure in the system, then you got to go back to what we learned in physiology with our low effective circulating volume. What are the things that our body's going to try and do to combat low effective circulating volume? One of them is going to be the whole renin cascade, get that going, and ADH release for the vasoconstriction purposes. And what ADH will do in the kidney with free water reabsorption, helping to expand the blood volume to bring the pressure back up again. So the vasomotor system, again, and this is our body's way to combat autonomic dysfunction, or when we stand up real fast, to make sure that we don't get lightheaded and dizzy. And let's talk about hokum. Okay, hang on a second. Okay. So what is important to know about hokum? Okay. genetics is a big part of it. Okay. Number one cause of sudden cardiac death in young kids. Other things to know, because of the way it's a genetic abnormality, the sarcomeres don't line up properly. You see a whorl pattern on histology looking at that type of muscle. Now, the big thing that happens with HOCM. Okay, there's our right ventricle, left ventricle. This is a normal situation, but with HOCM, the septum gets bigger. It hypertrophies. When this septum hypertrophies and when the heart squeezes, the aortic valve is right there. So what happens when we have a HOCM, hypertrophic cardiomyopathy, it causes a left ventricular outflow tract obstruction. The septum blocks the aortic valve in a way, also known as a subvalvular stenosis. It's not aortic stenosis, it's subvalvular because the issue is below the valve. The issue is because you have a hypertrophied septum. When the heart squeezes, that septum can get into the way of the outflow tract of all this blood leaving, causing a murmur to occur. It's going to sound like aortic stenosis. And make sure you know what happens when you do Erb's point and you have the patient do Valsalva maneuver. The next question has to do with the types of hypertrophy. All you have to know for this class, if they have aortic stenosis, they get a concentric hypertrophy. If they have aortic regurg, eccentric hypertrophy. It's going to be on the echo report. The cardiologist who reads the echo is going to explain everything, and he's going to say, I see evidence of left ventricular hypertrophy or concentric left ventricular hypertrophy due to or what aortic stenosis or whatever. But the report is going to tell you. The echo that you do is confirmatory. You're going to hear and auscultate on this patient, and you're going to hear these murmurs. You're then going to order the echo to confirm what you're hearing on your stethoscope, on your auscultation. You should know what you're going to find on the echo based off of what you are listening for. Similarly, when you start learning about EKGs, your first class of EKG is tomorrow with Dr. Avai. She's very excited. You're going to learn how to localize MIs, like we mentioned before. So knowing the territories that the coronary arteries perfuse. If you see lateral changes on an EKG, well, we know the lateral left ventricle is supplied by the circumflex. So if I see lateral changes on the EKG, I'm going to order a stress test, or they're going to go right for a catheterization, depending on how severe everything is. But you should have an idea, well, they got some lateral changes. It's probably their circumflex that's going to be causing the problems. You kind of have an idea where to look. If they have an anterior changes, that could be your left main. It could be your LAD. Those are the arteries that perfuse those tissues. You should know already what vessels you're looking for. So hopefully that answered your question about that one with regards to concentric and eccentric types of hypertrophy. And so Next question has to do with why some valves have an S3, some have an S4 present. So remember S3, ventricular filling, S4, atrial kick. So, valvular issues, let's look at them. Which one has an S3, S4? So, aortic stenosis. That can have an S4 present. If it does, again, atrial kick, trying to get that last little bit of blood in there so that you have a good preload for that aortic stenosis. Remember, aortic stenosis needs preload. You can't get rid of that. So having that mitral, that aorta, the atria, have that little atrial kick helps get that last little bit of blood in there to help with the preload. Where's the next one? Okay, aortic regurg may have an S3 present. Okay, so it's ventricular filling, it's blood coming in. With aortic regurg, you're getting blood coming in two different areas. Remember, you're having ventricular filling, so you're getting a big bolus of blood from the atria and from the aorta coming in, gives it a big drop. That is your S3 for your filling problem with that one. With mitral stenosis, obviously you're going to have an S4 because now you need your kick in there. And those are the big ones. Okay, next one is, why do dilated cardiomyopathies eventually progress to biventricular failure? When you have a dilated cardiomyopathy, the contractile proteins don't line up right. That's bad drawing there, but the proteins don't line up. You can't generate enough force. The heart gets very floppy. So with a dilated cardiomyopathy, the heart gets floppy. It doesn't squeeze very well. Remember, in a dilated cardiomyopathy, the chamber size itself gets very, very big. The walls get thin. And when the walls get thin, they don't work very well. Again, the contractile properties don't line up right. They can't generate any force, and you get a biventricular failure later on. Type 1 hypersensitivity reaction. This is your A for the allergy type. So it's either going to be an atopy, which is usually like a skin reaction. So something reacting to a food that you ate. Allergic reaction, a peanut. That is a type 1. The worst type is the anaphylactic. That's where you get angioedema going on. This mainly is due to, remember, IgE and caused by histamine. Histamine gets dumped to the system. You get vasodilation, leaky capillaries, and you get swelling going on with all that. Type 4, this is your delayed because it's T cell mediated, which takes time. So with delayed type 4, this is your poison ivy. Poison oaks, nickel allergy, your TB test, Those are all type 4 reactions. They're delayed, it doesn't happen immediately, but it takes a little bit, 24 to 48 hours for a response to kick in because this is T cell mediated. It takes a little bit of time for this one to kick in. Okay, next up is etiologies of aortic regurg. So when it comes to aortic regurg, the things that are important to know is it acute or is it chronic? Chronic AR, they have time for compensation. Acute AR, there's no time for any compensation. So when you keep that in mind, then you're going to look at the scenario that I presented to you in a case. What's the scenario? How are they presenting? What is going on with the heart? Are they in flash pulmonary edema? What is going on? What kind of pulses are you hearing? With acute AR, there's no time for a compensatory mechanism, so there's no displacement of the PMI because there hasn't been any dilation yet. With chronic AR, you have those bounding pulses. They're very dynamic when you're feeling for them. The diastolic rumble is going to be there as well with both of them because it's AR. But then on the next slide, it kind of goes through different types of valvular problems. That could be a cusp issue. Anything to do with endocarditis, long-standing issues take a while to develop. The acute issues, what else? Where are they? Lupus can be an acute issue. Aortic aneurysm would be an acute issue what causes an acute regurgitation. So again, how is the patient presenting? Why are they here? What happened to that patient that can cause them to be here? And then you get your rest of your history. Question about, can mitral regurg cause Ortner syndrome like in mitral stenosis? The answer is no, because with mitral stenosis, remember we talk about mitral stenosis being a pressure problem. And when you have a pressure problem, the heart, the atria has to squeeze more, causing left atrial hypertrophy. You get that with mitral stenosis from having to always squeeze against a fixed obstruction, which is the stenotic valve. So when that happens, you get left ventricular hypertrophy, and when that left atrial hypertrophy, and when that atrium gets thicker and bigger, it will pinch that left recurrent laryngeal nerve, and that gives you the hoarse voice for the Ortner syndrome. Mitral regurg causes more ventricular problems because you're going to volume overload the ventricles now, because it's not only are you getting the blood from the venous return coming from the pulmonary system, but the majority of that blood that was supposed to leave the heart, some of it went back up into the atria. So the atria are getting doubly filled, and therefore the ventricles are getting overfilled as well. Okay, so the question is, with aortic regurg, sometimes S1 can be soft or absent, but why is it S1 and not S2? So with aortic regurg, let me go to my notes. Okay. Okay, I don't see where I talk about aortic regurg having that issue. I know with stenosis, stenosis has a soft S2 with aortic stenosis. The reason why you have a soft S2 with aortic stenosis is because remember with normal S2, it's the closing of the aortic valve. So when you're clapping from a wider area, it makes a louder noise. But when you have a smaller orifice, it makes a smaller, a quieter sound. So with aortic stenosis, you will lose S2. I don't see if you can tell me what slide it was on about the other one. With regards to that aortic regurg. I'm looking through the notes from class. I don't see anything. Slide 98, okay. So 98 is all the causes for aortic regurg. Under acute AR. Oh, I see what you're saying. Okay. I'm trying to think that one. I'm trying to think of this one through. Hang on 1 second. I don't know exactly. It's obviously not going to be a question on your exam for tomorrow, which is not the best answer in the world. But I honestly I can't think right now as far as why. Let me look. Hang on. Okay, so S1 is soft because of the elevated left ventricular end diastolic pressures closing that valve prematurely. So the mitral valve closes because remember, what's keeping that mitral valve open? It's the fact that there was higher pressure in the atria than the ventricle. So just due to pressure changes, it's going to fall down. Because an aortic regurg, you're already going to have a little bit of blood already in the heart waiting there because of the regurgitant vessel while you're filling at the same time. The pressure is going to equalize faster. So the mitral valve is going to close prematurely. So therefore, that's why it's going to have a soft S1. Has to do with pressure changes. Just happens faster. So yes, so we answered that question. So any other questions? Sure. You're welcome. So for the first lecture, inflammation, make sure you understand all the 5 cardinal signs of inflammation and healing and why you get each of those signs. Know the 4 hypersensitivity reactions, and then just a little bit of what we talked about with HIV/AIDS and a little bit about lupus as well. That's really it from that first. Also, sepsis. Make sure you know the different types of sepsis, the different stages as you go across, what's important with each one. When it gets to the cardiovascular stuff, we had started off with electrical issues. So heart either going too fast or too slow. Know the causes for bradycardia. Know the causes for tachycardia. For Brady, there are 2. For tachys, there are 3. So make sure you know all those. Then we go to the cardiomyopathies and heart failure. So the questions are going to be very similar to kind of what we did in class when we talked about the case studies. So you'll have a scenario, a patient shows up complaining of shortness of breath. You listen to their heart and they have these heart sounds. They have these symptoms. What valve do you think is causing the issue? And obviously all 4 valves have very distinct things about them. So if I give you a question about a valve and the 4 answers are going to be aortic regurg, aortic stenosis, mitral regurg, mitral stenosis, and I mention a crescendo, decrescendo, systolic murmur, know right away, is this a systolic murmur or diastolic? If it's systolic, what are the only 2 murmurs it can be? If it's diastolic, what are the 2 diastolic murmurs? That'll knock out half of your answers right away. Then go over the characteristics. Where is it best heard? Right upper sternal border, left lower sternal border, mitral, aortic. That gives you clues. The symptoms that they're having, what kind of heart sounds do you hear? Those are all things that you're going to be responsible for. Explaining what happens with atherosclerosis, what are the different stages involved, what happens when you get occlusions. Someone's coming in with intermittent claudication. What is the underlying etiology for that? So what causes intermittent claudication? So remember, we talked about atherosclerosis. We talked about atherosclerosis as far as in different scenarios, depending on what parts of the body you have affected with the atherosclerosis. So we had said, if it happens in the brain, you get a cerebrovascular accident. If the atherosclerosis is in your coronary vessel, that's coronary artery disease. If the atherosclerosis occurs in your peripheral vasculature, then you have intermittent claudication from peripheral arterial disease. So it all depends on where they're having their problems. So you're not going to be diagnosing per se, but you will diagnose the heart murmurs as it relates to the physical exam and so forth. Okay, so atherosclerosis starts always with vessel disease. You have to have a tear in the vessel. Let me get this up. Hang on. Hypertension. Okay, here we go. Atherosclerosis. So shear stress. Okay, remember, mainly going to happen at the bifurcations. That's where the shear stresses are highest. That's where we get the injury to happen to the vessel. So that causes the injury. Then in that injured area, LDLs are oxidized. They get inside, mix with macrophages, and that causes foam cells to occur. These foam cells cause the fatty streaks to occur. These fatty streaks, you already have them all in your aorta, and then over time, more vessels become affected with the atherosclerosis, and you get more and more of these fatty streaks going on in different parts of the body. So these fatty streaks are there. The last thing that happens in the repair process is all this occurs. We'll call it this. Ran out of space. Endothelialization. Well, the smooth muscle, not really the smooth muscle, and the intima cover those foam cells. Basically makes a kind of a plaque. It seals it in. So what happens is we go from here's one vessel. Now this vessel has undergone atherosclerotic changes. We have an injury to that area. Next thing that happens, this injured area is still there, but then we get a fibrous cap. We try and endothelialize that foam cells, the fatty streaks, get all that inside the layer and seal it up. But as you can see, when you do that, the lumen size obviously decreases. So therefore, the supply is going to decrease going through those areas. Now, this is where the problem happens. If that little fibrous cap ruptures and it breaks due to prolonged high blood pressure, prolonged uncontrolled cholesterol issues, if this plaque cracks, platelets are going to come in there and try and seal it up because you have an injured vessel. Platelets are going to come in there and they're going to seal it up as well. And now you may cause what's called a complete occlusion because of all the platelets that got in the area due to the plaque that ruptured. It cracked. We sealed it up really, really nice, but due to high blood pressure, whatever, smoking, continued smoking, that plaque ruptures and it causes a full-on occlusion due to platelets trying to fix the area. Now you get a full-on thrombosis blocking the area, so anything downstream is going to become ischemic. Okay, so I hope that answered your question regarding the stages of atherosclerosis. We are going to start derm first next week when we come back. You guys are doing derm first with CMS before POEM, so we'll do derm. We'll do it next week, and then we'll do POEM after that. Hopefully today with PD starting, things will start getting into place where you're going to start getting the medicine And then you're going to put the PD skills behind it. And as you go through PD, do your ENT ophtho exams, all the different things that can go with the eyes and all the different things, you start figuring out what questions to ask, how to get a good history for all those things. And then pharm kicked in, and then you're going to learn all the ENT ophtho drugs and the different drops. So hopefully now that things are kicking in, things will start making sense from all the different CMS classes. You guys start EKG tomorrow. So you're going to refresh all your stuff about all the electrophysiology and action potentials to see how EKGs are formed. As we start getting into the other diseases, other systems, it becomes more focused on specific things. As you guys gathered from physio with cardio, it's all over the place. We get to pathophys again, it's all over the place because of how much the heart is affected by what happens in the vasculature. The heart itself is a pump. Um, Always try and relate things that you're learning to things that you know every day. If you have a pool or you grew up with a pool, my pool pump broke a week ago, so the pump was not working. The pump is the heart of the pool. The pump was dead. So no pump, there was no flow. Because there was no flow, nothing was filtering all the bacteria and the algae. So the algae went nuts in my pool. All because the pump was failing, which leads me to the different types of shock. So make sure you know that the 4 different types of shocks. Know that which one provides warm extremities. All the other ones are going to be cold, clammy, but one of them is going to be warm. Make sure you remember which one is the warm one. Make sure you know what are some underlying causes for different types of shock. Obviously, if I mention something about cardiogenic shock, I have to mention something about a massive heart attack. The pump is not working, pump failure, it's out. There's no movement of blood really anywhere going on. Just like in my pool pump broke, there was no movement of water anywhere, nothing was happening. You have your hypovolemic. I have to mention something about severe dehydration, profuse vomiting and diarrhea for 3 days. They're not able to drink any water. They can't keep anything down. That patient is going to be severely dehydrated. They're going to have hypovolemic shock if they go into shock later on due to that. But again, look at the history. What is the vignette telling you about that patient? If they say they fell off a ladder and they they injured their spine and now they have spinal paralysis from T4 all the way down. Well, that's a neuro cause, spinal shock. That's going to be that type of shock. So make sure you know the obstructive shocks. It's going to have something to do with blocking blood flow. DVT causing a massive PE, causing extreme strain on that right ventricle, putting you right into right ventricular failure. Those are obstructive causes. So as you're learning, there are 4 different types of shocks, because when you go into cardio, they're going to say this is a result in a distributive shock. Well, now you understand what made them go into a distributive shock, what made them go into a hypovolemic shock. The purpose of pathophysiology is to give you the underlying causes for the types of things. CMS will tell you this person gets this type of shock, this person gets this type of shock, so on and so forth. So that's kind of how you start putting things together. Again, there won't be any major diagnoses or treatments. There's no treatments at all. Diagnoses mainly due to different, what do you hear on your auscultation? You can make a diagnosis based off of auscultation with the heart. Okay. Any other questions? Your little vacation's almost over. Next week, you go right back to full-time schedule all week. And all your fun exams get piled up again. So, once the site visit's over, we'll be a lot happier. We're happy, but it'll be nice when that stress is off. Make sure you know the different causes of high blood pressure, the secondary causes. These are the known causes. These are usually the treatable ones that you can take care of. So make sure you understand the different types. Let's see. Make sure you understand DVTs and how they start. Virchow's triad, Beck's triad for pericardial effusions. Make sure you know that one. You know I like my charts, so all those algorithms that show that what happens with high blood pressure as you go through different areas, what the high blood pressure does to the vasculature and the heart. So when you're looking at the heart, remember we always say cardiovascular system. But it's the cardiac, what is actually happening to the heart itself, the pump itself, and what is happening to all the pipes that it feeds to. Because the vasculature does affect the heart. So therefore, is this a vascular problem causing an effect on the heart? Or is this a true cardiac issue? Where coronary artery disease is a vascular problem causing a cardiac muscle problem. But the problem is the vasculature. You need to open up the coronary arteries and then your heart function will improve. That's a vascular problem. It's not a cardiac issue. It's just a result of the vascular issues. High blood pressure is a vascular problem. It's not a cardiac issue. It's a vascular problem that the heart has to work with and causing you get LVH and all the other issues. Another way to look at things with the cardiovascular system is that, is this an electrical problem or is it a plumbing problem? Is it an issue of plumbing? Is it the vessels or is it an electrical problem? Is it the heart's in an abnormal heart rhythm, therefore you're having filling issues because of the electrical problem causing hemodynamic issues? So when you're looking at arrhythmias, those are electrical problems. Sometimes you will have electrical issues caused by the heart. A lot of patients who have mitral stenosis, because that left atrium gets enlarged and thicker, left atrium doesn't like it, starts sending off a lot of signals. So you see a lot of patients with atrial fibrillation with mitral stenosis. It's that abnormal discharges. It's an electrical problem caused by the heart itself. So electrical plumbing, is it plumbing or electrical or the plumbing? Is it like chicken or the egg? What happened first? And that's part of what learning in these next 2 semesters is learning about, is the nuance of medicine. Is this how to look at your history, what questions to ask during the history, what physical exam things do you want to listen to rule in or rule out different diagnoses that you think. It sounds like a lot, but don't stress out about it. It'll happen at some point to everyone. It'll happen. Okay. The question has to do with re-entry rhythms, these re-entry tachycardias. There are the 2 main types that we talked about in class is the AV node re-entry tachycardia and the WPW are the 2 ones. Both of them have one pathway and then a side or accessory pathway, especially the WPW. With the whole thing is when the impulse comes down, action potential comes down, it's going to go down the fast one really fast and then get through the AV node down to the ventricle. But then we have a slow pathway. The slow pathway meanders around, takes its time, does its own little thing. But when it gets here, it stops because the fast pathway is in a refractory period, an absolute period. So this impulse can't get through. So usually in a normal system, normal circuit, everything follows the fast pathway or the normal pathway. This is talking through the AV node right here. If we did WPW, here is our AV node, and this is where things should follow normally. But in WPW, they have an extra pathway right here. This extra pathway is the slow pathway. And the AV node itself, the entire thing, is considered the fast pathway. This is how we're set up. The key thing when it comes to these re-entry tachycardias, you need a premature beat. You need a beat to happen at a time that it was not supposed to occur, so that when the new beat occurs, the extra beat, the APC or the PAC, whatever you want to call it, this signal comes down, follows a slow pathway, but when it hits the fast, because this was in an extra time that it should not have happened, the fast pathway is now excitable. It is now ready, and all the gates have reset. All those sodium channels have reset the inactivation gates back to normal. And if an impulse comes along at the right time, it can send another action potential. So as this APC comes in, it hits the fast pathway, which is now excitable, sends the signal back up the fast pathway, and it starts cycling on itself. We get a cycling of the rhythm. So as it's cycling on itself in the AV node, it's sending signals up and signals down. Same thing with WPW. Normally, the beat comes down, and by the time it gets up to this accessory pathway, it's in its refractory period. It's not going to do anything. But if an abnormal beat happens at the right time, when this pathway sends the signal down, now the fast pathway is now excitable. Same exact thing on this side. Signal comes back up in the atria, back down that accessory pathway, and this is how you get your cycle on WPW, on the re-entry tachycardias. It's the same principle. It has to be an extra beat thrown in there. So patients who have WPW, because they have this accessory pathway, you have to ablate that. So this you ablate. You cryogenic, radiofrequency ablation or cold ablation, they cut the electrical pathway so that you can't get this circuit. Because on a patient with WPW, if they go into like atrial fibrillation or an abnormal heart rhythm, that you can cycle on itself and all those rhythms go down and you can get really, really fast heart rates. So if we know they have WPW, and on this one, EKG, delta wave. Whenever you hear a delta wave on an EKG, think of WPW. That's the only thing it's going to be. Delta wave with a QRS complex, WPW every time. Okay. So WPW is not, well, so SVT is a supraventricular tachycardia, which means any tachycardic rhythm that is originating in the atria. So yes, technically WPW would be an SVT, but yeah, technically yes, it is an SVT, but you don't want to look at it that way. Most of your SVTs are your atrial tachycardias, atrial flutters, atrial fibrillations, wandering atrial pacemakers, multifocal atrial tachycardias. Those are all weird things that happen in the atria. You'll learn all about those things in EKG. So when I refer to the right time, that fast pathway, that signal is going to go down the fast pathway very, very fast. But then we have our absolute refractory period, then our relative refractory periods. But as that slow pathway makes its way down, when it hits where the fast pathway is, the fast pathway right now is still in refractory. Nothing's going to happen, so the signal just dies off. But if you have an extra beat that happens randomly, the slow pathway maybe make its way down to the fast, and by the time it hits there, the fast pathway is now reset and ready to go again. So when that happens, if it's excitable, that charge will pick up that fast pathway, go back up to the atria, which then come down the slow pathway, hit in the fast, back up again and back down, and back up and down, back down. And it makes a cycle, and it cycles on itself, causing that re-entry rhythm. That's all we do. If it's AV node re-entry tachycardia, we ablate the slow pathway so that it won't happen again, and we keep the fast pathway the way it is. When my first job as a PA was in electrophysiology, which is dealing with all the heart rhythm problems and everything, and the patient, had this AV NRT, and my doctor we're going to ablate the slow pathway, and when you do that, here is your atria. We know that your AV node is down here. So we have an electrode, and we place this electrode. It comes down, and it just lays right across here, and it has little dots on it. And you can figure out what pathway is going on with each dot. And then you send a signal, and it ablates the node. Accidentally, he ablated the entire AV node. So when you do that, they go immediately, when you ablate the entire AV node, they go immediately into third-degree heart block. There's no communication at all. And then you get an automatic permanent pacemaker when that happens. So third-degree heart block gets a pacemaker. Okay, so I'm glad that answered your question, Daniela. Any other questions? Make sure you know all the different things about pericardial, starting with pericarditis, and then working its way to constrictive pericarditis, pericardial effusion, pericardial tamponade, all those things making things worse. That's where Beck's triad comes in with pericardial tamponade and infusions. What else? Know the different types of chest pain Stable, unstable angina, what the difference is, the different percentages needed to elicit chest pain in those types of patients. There's no EKGs on this thing. Okay, I'll give you guys another minute or two. If there are more questions, we'll end this early tonight. I'll stick around for another minute or two. Make sure you know heart failure. So with regards to stroke, ejection fraction, so if it's preserved EF or reduced EF, what are the differences? Is it a filling issue or is it a squeezing problem? Where does it come? A lot of it is all be symptoms. Why are they getting these symptoms? Why are they getting this symptom? What's happening here? Why do they get this? If they have this symptom, what does it mean? Those are the important things with regards to that stuff. Okay. Okay, so there's no more questions, so we'll call it for the evening. Good luck, everyone. You're going to do fine. I'll see you all in the morning. Good luck. Get some rest tonight. And I will see you all then. Have a great evening.